welcome to SSMC Answers. My name is Matt Getman, Chief Medical Officer here at SSMC, and I'm thrilled that you've taken the time today to join our program. As you might know, SSMC is one of the largest hospitals in the UAE, and we are here to treat patients with serious and complex medical problems. We believe in the power of care, and we also want to deliver care that's done in a holistic way, where we think about the impact of disease to the mind, the body, and the spirit. We also want to provide patients and family members alike information about common medical problems, and when possible, put an emphasis on prevention of disease. In each of our SSMC Answers sessions, we invite key members of our staff, experts in the field, to talk about a given topic. Today's topic is thyroid cancer, and I'm so honored to have three of our experts from SSMC that will be part of the program today. First, I'm happy to introduce Dr. Salma Harthi, who is consultant and our chair of the Department of Surgery. Next, I'm happy to introduce Dr. Sami Melki, who is consultant and our expert in the Department of Ears, Nose, and Throat Surgery. And last, Dr. Hassan, who is joining us from the Division of Endocrinology, where he is also a consultant. I think it's going to be a great discussion today. I'm thankful for you all joining. First question, Dr. Hassan, is tell us a little bit about what is thyroid cancer? How common is it worldwide? How common is it in the UAE?
Sure. Yeah, so thyroid cancer happens like any cancer when a change in the DNA of the thyroid cell happens. That's called mutation, and that makes the thyroid cell divide somewhat faster than usual, and eventually that will cause a mass in the thyroid, and that's called tumor. And this tumor, about 50% of the time, may travel to lymph nodes around the thyroid glands, and rarely it may travel further to other organs in the body, like bones, lungs, liver, etc. It is widely common. It depends on what reference you look at. It depends on what population you look at. It's estimated to be now between the 5th and the 9th most common cancer among all other cancers worldwide. In UAE in particular, it's estimated to be actually the 3rd most common cancer. Now, why it's that common, or it's kind of debatable whether the incidence is increasing by itself, or in fact most of us believe we're just detecting it because more patients are getting scans, CT scan or MRI of their neck, and incidentally we're picking them up and then knowing about the thyroid cancer. On autopsies, it's found that about 35% of people had thyroid cancer not even knowing about it. So it's widely common.
Okay, so when we think about these growths that are, or lumps that are happening in the thyroid, what are there different types, or how do you categorize the different types of thyroid cancer?
Sure. So the most common type of thyroid cancer we deal with and see often, it's called papillary thyroid carcinoma, and then the follicular thyroid carcinoma. Those are, to the most part, differentiated, meaning well-behaving. They are, to the most part, slow-growing. And then we have the more aggressive types. They are like medullary thyroid carcinoma or anaplastic thyroid carcinoma. Luckily, those are not common. We rarely see them in population.
Okay. Dr. Sami, what are some risk factors for thyroid cancer?
Yes, thank you. So there are historically, you can see, for example, radiation, ionizing radiation exposure as a child is one of the main risk factors. As in history, they used to use radiation for many common issues like acne, for example. We know of Chernobyl, for example, where kids were detected with more thyroid cancers than others. Then there's also the family history as well. So if you have a strong family history for a specific type of cancer, sometimes that can be a risk factor. And there was also historically in iodine deficient areas as well. They had a higher rate of goiters and some with also thyroid cancers.
When you say goiter, what is a goiter?
A goiter is essentially when you have an enlarged thyroid. It's a catch-all term. It doesn't mean a specific disease, really. It's more enlarged thyroid.
So when you have an enlarged thyroid or the goiter, then that's going to be symptomatic. So, Dr. Salam, what are the symptoms that are seen commonly with thyroid cancer?
So with thyroid cancer, the most common symptoms is a swelling in the center of the neck that moves with protrusion of the tongue or with swallowing. Sometimes when the tumor goes large, you can have difficulty in swallowing, and at that stage there is a compression on the esophagus. Sometimes you can have difficulty in breathing when there is a compression on the trachea. And with malignancy, if there is infiltration, you can have change in the quality of your voice. That's called dyspnea or dysphonia, and that means there is an invasion of the recurrent laryngeal nerves.
Okay, so those are all the advanced cases, and that's what we would read, of course, in a textbook. But now it sounds like with imaging, Hassan, you're seeing it different, where it's asymptomatic.
That is correct. In fact, most of the patients, they are asymptomatic, meaning they have no symptoms when they are diagnosed with thyroid cancer. For two reasons. Number one, thyroid cancer in general doesn't cause pain. So when patients come to me with neck pain, normally I reassure them this is actually good. That means it's a sign of inflammation, infection. Thyroid cancer itself does not usually cause pain. And number two, it will not cause the compression symptoms that we're talking about, meaning the pressure on the vent tube, and that causes shortness of breath, or the compression on the tube that connects into the stomach, and that will cause difficulty swallowing, or a compression on the nerves that supply our larynx, and if that happens, then that will give a change in the voice or hoarseness. Those symptoms happen only if the tumor is so large. So usually when it reaches that size, oftentimes patients already detected that mass on their own even before seeing the doctor. So that's why oftentimes patients don't have symptoms, but of course some Dr. Salam mentioned.
Well, it's reassuring that patients are presenting most commonly in an asymptomatic manner, but when patients do have symptoms, Dr. Melki, then what are those steps, what are those processes that you go through for the examination to really kind of figure out what you're up against?
Right, so we, typically these patients present to you as a neck mass, right? So we don't know what they have. And so they have to undergo basically the whole battery of exam, history, everything to basically get to a diagnosis. Because in an adult, above 45, we consider a neck mass as cancer before anything else. And so you get a full, thorough history. You check for any history of cancers, including thyroid cancers. And then you're gonna go and do a full head and neck exam, see the quality of that mass, how big it is, how mobile it is, what structure is it attached to. And then you're gonna do an endoscopy, which basically means putting a camera down the nose, looking at the vocal cord and the mouth of the esophagus, or and then see if there's any abnormality. Are the vocal cords moving? So if one of them is not moving and you feel a mass, so left side is not moving, mass on the left side, you start thinking, okay, this is probably in the thyroid on the pathway of the recurrent laryngeal nerve. And so once you have done that and you think that there is a cancer or any serious disease, then you have to order imaging as well as blood work. So the imaging of choice for thyroid in general is an ultrasound. The ultrasound is better than a CT or an MRI in categorizing really the lesions inside the thyroid. And that's why there are multiple scores that the radiologist will use to basically give you a chance of this being cancer or not. And so you got this ultrasound, and when they see the lesion, they can put a needle in the lesion, get a few cells, and send it for pathology. And the pathologist should be able to tell us, is that cancer or not? That's the typical process that we follow. We also order lab tests to know what's the thyroid function looking like. Is it normal? Which most of the time it is. And then once we have a diagnosis, then we can move on to what the treatment should be.
So, Dr. Salam, tell us about the multidisciplinary approach that we take to cancers here at SSMC.
Okay, well, patient will be seen initially by a physician or a surgeon, and we will do the blood test, we'll do the radiology investigation, which is mainly ultrasound. If biopsy is required, biopsy or cytology will be done, and that will be examined by a histopathologist and will give a report. And the rest of the imaging, if required, will be done, but it's mostly an ultrasound. Then the case will be discussed at a multidisciplinary team where you have an endocrinologist, there will be a surgeon, there will be head and neck surgeon, there will be the oncology and the radiation oncologist, and the pathologist will come and present the slide. And then we look at all the aspects of the case. So we look mainly at the risk factor the patient has. We look at the classification and the risk factors on the ultrasound findings, and we look at the pathology. Then the team decides on the treatment approach for that patient.
Okay. And Dr. Hassan, can you tell us about how the thyroid cancers are staged?
Sure. So it is usually staged after the surgical removal based on the size of the tumor, based on if it traveled to other locations, lymph nodes, or other organs like lungs, bones, etc. And that will tell us if it is stage 1, 2, 3, or 4. And usually the lower the number, the better prognosis, and vice versa.
And then if the number goes higher, then are there other treatments that would be needed to manage the thyroid cancer?
Yes, so there are other, in addition to surgery, there are other things we do to manage those patients. The most common would be the radioactive iodine treatment. So the thyroid cell, whether it's benign or malignant, they love iodine. It's the food for the thyroid cell. So we use that iodine as a way to kill or at least slow the growth of thyroid cancer by being radioactive. So it's a pill or a solution the patient will drink only one time session normally, and oftentimes done as inpatient in the hospital. The patient will stay for a couple of days, unless if it's lower than it's low dose, then it's done as outpatient. And usually it's oftentimes doesn't have much side effects, if any. If in more advanced cases, which are not that common, luckily, then patients may need localized radiation treatment or chemotherapy, which is done with either radiation oncology or the cancer doctor, the oncologist.
Okay, good information. Now, what we learned already is that not all of the thyroid cancers are big. Many of them are asymptomatic. So, Dr. Salam, it leads us to the question: and we know that some are not aggressive. Do all thyroid cancers need to be treated surgically?
Okay, that's a good question. So we look at the risk factors of the patient and we look at the size. So anything that's less than 1 centimeter, we don't even take a biopsy. We just observe them, and we can just repeat the ultrasound in 6 months or even 1 year. And after 1 centimeter, we will consider fine needle aspiration. And if the diagnosis of cancer is made, we can still ask the patient to wait. We don't have to really operate if there's minimal risk factors, and we are happy with the features on the ultrasound. But yes, we have a diagnosis of malignancy, but up to 2 centimeters, we can still wait and see. So yes, the operation is the treatment of choice, but because they have a good prognosis, the outcome is so good, and stats said 85 to 90% of patients would live up to 10 years without any problems. So yes, they need surgery, but they can wait and just do a follow-up until they decide to do the surgery.
Okay. Now, Dr. Sami, if there's the thyroid is 2 sides to it, on either side of the windpipe, right?
Right.
So if there's a mass that's just on one side, not on the other, do you take the entire thyroid, or you just take the bad part?
Well, again, it depends. So typically it goes down to the size, and also if it's multifocal. So sometimes you would have, so if it's a small one, sometimes you remove half the thyroid. But then your pathologist will go and examine and say, okay, there are multiple small foci, more than 5 foci which has other sites of small tumor deposit inside the thyroid as well. And so if it's more than 5, then you have to go and remove the good side as well. But if it's less than that, then it could be sufficient to remove a small tumor on one side and leave the other side alone. So it depends, and then obviously depends on if there's any invasion to the vessels, if there's any high-risk features that are specific to the cancer. So there's something called tall cell, for example. It's a specific type inside the papillary, the differentiated cancer. So in that case, this is a high-risk feature. You should probably go and remove the other side of the thyroid.
Hassan said that sometimes it's spread to lymph nodes. So then when do you decide to do the lymph node dissection?
Right, again, so sometimes you have the answer preoperatively when you are doing your ultrasound or your scans and you see lymph nodes that are enlarged. In that case, you can choose either to biopsy them with a needle, and if it's cancer, then it needs to be removed, or you decide to remove them prophylactically if they're big enough and suspicious enough on the ultrasound. And the second case scenario is that you go do your surgery, and in surgery, you see lymph nodes that are enlarged. And you can take one of them out, send it to the frozen section. They can tell you, oh, it's cancer. And so you have to remove the lymph nodes as well
So
in that case.
And this talks about something that's a differentiator for us here at SSMC. You mentioned the fact that you can take a piece of tissue during the operation,
Right.
have it analyzed by the pathologist during the time of the operation, give you the information. That's called frozen section.
Correct.
That's something that we have here at SSMC so that we can do the right operation for the patient while it's happening, which is
Exactly.
really, really great. Dr. Salam, you've got the thyroid, but then there are also what's called the parathyroid glands, which are very important for how calcium is handled in our body. They are so close to the thyroid itself. How do you manage those parathyroid glands during the thyroid operation?
Okay, so this is one of the common complications of thyroid surgery. You need to preserve the 4 parathyroid glands, and also you need to preserve the recurrent laryngeal nerves. And these are the complications patients are always asking about, worried about, and they always think about them. So we stick to the thyroid gland. So sometimes it's easy to identify. The parathyroids are small. They are yellowish in color. They are different color from the thyroid, but it's not always easy to identify. So we try to stay as far away from them as possible. If you can see them, that's well and good, but if you don't see them, just stick to the capsule of the thyroid gland. So just stick to your target, stay away from them, and most of the time we just disturb the vascular supply. You are away from the parathyroid, but because you divide the blood supply to the thyroid, which also supplies parathyroid, they can drop their function for a week or so, but within a week or 2-3 weeks maximum, they will recover back to normal. So we try to stay away from them, stick to the thyroid gland, and for the nerve, we use something called the nerve monitor. So the nerve monitor is some stimulator, nerve stimulation in the theater that can help you to identify the nerve, preserve it, and stay away from it. And at the end of the procedure, we make sure the nerve is intact, and we document that in the patient record. So the NIM is a mandatory for us at SSMC, and no thyroid surgery will be done without nerve monitoring.
So this is good information, and it sounds like because the nerve is, you know in general where it is, but you have to be absolutely certain where it is at all times so that you have less impact on the patient.
Yes.
Now, the issue, of course, is that thyroid hormone and parathyroid hormone then are critical body functions. So after surgery, then what happens from a standpoint of replacement therapy?
Sure. So of course, when the whole thyroid gland is out, then patients will need to be on thyroid hormone pill every day indefinitely for the rest of the life. If only half of the gland is out, then maybe 50 to 70% of the patients will not need thyroid hormone pill because the other half will compensate and will keep the level of the thyroid hormone normal in the blood. But when the whole gland is out, then definitely those patients will need to be on replacement, and that comes in a pill form. Usually, for thyroid cancer patients, we purposely give it in higher doses. We call it supraphysiologic doses, because doing so will decrease the risk of recurrence of thyroid cancer. And usually it's a pill taken on empty stomach in the morning, usually at least 30 minutes away from breakfast or even coffee, to make the absorption the best. As far as if the parathyroid glands were damaged, so patients will need to take calcium and vitamin D, usually transiently, because most of the time the function of the parathyroid glands will recover. But if sometimes they don't recover, and in that scenario, those patients will need to take calcium and vitamin D as well, and definitely every day. And those usually are being monitored by endocrinologists like myself to adjust the doses according to blood work that we do every now and then.
Good, and good to know. Now, Dr. Melke, tell us about the postoperative recovery after thyroid surgery.
So, thyroid surgery, when done here, usually has a very, I would say, relatively easy recovery. The pain after surgery is usually not too much. Most of our patients can leave the day after surgery. And what they need to watch out for is essentially making sure that they do not overstrain themselves, because there's an active surgical field that could bleed if they exercise or lift something that's very heavy. They also need to follow a recommendation in terms of taking their medication, their calcium, their vitamin D as needed per the endocrinologist. And also because, as Dr. Sam said, after surgery with the multidisciplinary team, we might decide they need radioactive iodine. So there's a specific diet they need to be on, and that usually we have a dietitian that helps us with telling them what exactly they need to be eating, especially to also make sure they're taking their thyroid hormone and it's well absorbed, because that can be very critical. Some patients do not realize how to take their thyroid hormone. So that education is done prior to their discharge from the hospital. And typically within 1 or 2 weeks, they can resume a normal lifestyle, active lifestyle with no issues, essentially. If they've had also an additional surgery, which is a neck dissection, which is the lymph node removal, that adds a little bit of complexity, a little bit more pain. Sometimes some patients need some physiotherapy, especially for the for the upper extremities, because that can be affected sometimes. But other than that, it's usually a very smooth recovery.
All right, so some questions are coming in. We'll go to those questions now. Dr. Salam, question coming in. How can you enhance the cosmetic aspect of thyroid surgery?
Okay, so at SSMC, we do the conventional surgery, and what we do is a transverse incision in the lower aspect of the neck, and that's about 3 centimeter maximum diameter, unless your goiter is huge. And we close the wound in a subcuticular fashion where they use absorbable suture, so you don't really need to remove anything. It's a cosmetic closure. Sometimes we use the glue instead of suture, so that's cosmetic. There are other cosmetic surgeries, but we don't see much of advantage to them. So there is the transoral surgery, but it has its own complication where you can go through the floor of the mouth, create a flap, do the thyroid using a laparoscopic surgery instrument. But this again has its own complications. So there is scarless surgery. There is no visible scar, but it has its own problems. The other thing is we can do endoscopic surgery where you create tunnels through the axilla, so transaxillary thyroidectomy. But again, you end up with ecchymosis, with a big flap, with hematomas. So we think we are doing the easiest and the most acceptable surgery, and we just look after the scar and close it in a nice
and it heals up well most of the time.
And it heals well within
Absolutely.
3 or 4 days.
Okay.
Yes.
Hassan, what about another question coming in? Thyroid cancer, can it be prevented? Are there any lifestyle changes that may reduce the risk of developing this condition?
Very good question. I get asked about it very often. Unfortunately, no. There is nothing we could do at this point that we know to prevent thyroid cancer from happening. So diet, it's not related. Lifestyle, it's not related. However, we could detect the cancer earlier in patients who are known to have risk factors. So it's kind of just to detect it earlier, is not to prevent it. So those patients with family history, mostly we're talking about first-degree relatives like parents, siblings with thyroid cancer, then it would be a good idea for those patients to get ultrasound of their thyroid gland every now and then. Patients who had radiation exposure to the thyroid in the past, that would be the second risk factor. Along the same lines, I would like to emphasize on something I hear often from patients. People don't know where the thyroid gland is. So they come, they are pointing about some swelling here, thinking that this is a problem with their gland. But in reality, I would like to take the opportunity here and educate the viewers that the thyroid gland is actually here in the lower part of the neck in the midline. So if you feel a swelling or a lump in that area, then that would be potentially related to the thyroid gland. But the swelling that many people notice in the upper neck here, it's usually lymph nodes, or people call it lymph glands. This can swell because of recent infection, viral or infection or bacterial, and oftentimes it go back to normal. So this has nothing to do with the thyroid gland.
Okay, good to know. Another question that's coming in, how does thyroid cancer affect fertility and pregnancy? What considerations need to be taken into account if you are planning to start a family after diagnosis? Sammy, what do you think?
Right, so if you've had only surgery and nothing else, and you're taking your hormonal replacement properly and your TSH and every hormonal levels are normal, I do not think, and I'd like to be corrected if there's any issue with fertility. However, if you've had radioactive iodine, obviously that cannot be given during pregnancy, and so because radioactive iodine is radioactive. But again, it just goes into the thyroid. It's absorbed in the thyroid. It will not go into the genital organs, so typically should not also affect fertility, but it could affect pregnancy in terms of, you know, the timing of treatment.
Okay, so last question, I think, before we wrap up, Dr. Salam, is there a hereditary component to thyroid cancer, and what genetic factors do we need to be thinking about?
Okay, that's a good question. So the answer is yes, there is a genetic component, and that goes mostly with the, so we have 4 types. We have the papillary, the follicular, and the medullary. So the medullary is, yes, there is a big hereditary component, and there's something called familial medullary carcinoma, and it's usually associated with a mutation in the red gene and other genes, and it's associated with other cancers of the endocrine system. So if you have a medullary thyroid carcinoma, we need to make sure you don't have anything in the pituitary gland and also in the pancreas, and look for pheochromocytoma, the suprarenal gland. So there's something called MIN1, multiple neuroendocrine tumors, type 1 and type 2, and they usually go hand in hand with the medullary thyroid carcinoma. So with medullary, we need to be aware of that. And if you have a strong family history, you need to test for it early in childhood, and sometimes you need to do prophylactic thyroidectomy. Sometimes at the first year of life, sometimes at the 5th year of life, or as early as it's diagnosed.
Thank you for that information. Again, making me want to come to SSMC before that expert multidisciplinary care. Our topic today has been thyroid cancer. This has been a wonderful discussion. I'm sorry that we don't have more time to go ahead, but again, I'd like to thank you, Dr. Hassan, Dr. El-Harthi, and Dr. Sami for joining us today. And I'm looking forward to additional conversations in the near future. Thank you so much.
Thank you.
Thank you for having us.